Hello, everyone. My name is Varun Jain, and on behalf of the Communications Committee of the ASMBS, I'm excited to continue this new initiative called SOARD Spotlight. Once again, this is an effort to not only increase the outreach and awareness around surgery for obesity and related diseases, or SOARD, which is the official journal of the ASMBS, but to add an interactive element by speaking with few of the authors, allowing access to unique insights, thoughts, and ideas behind their work. This is our inaugural March 2023 edition, and I'm delighted and honored to have Dr. John Morton joining us this morning. He is the Professor and Vice Chair of Surgery at Yale School of Medicine, Division Chief of Bariatrics and Minimally Invasive Surgery, past President of the ASMBS, and inaugural Chair of the ACS Committee for Metabolic and Bariatric Surgery. Welcome, sir.
Thank you. Pleasure to be here.
Yeah. Today, we'll be talking about the article titled, The Role of Pre-Operative Toxicology Screening in Patients Undergoing Bariatric Surgery. It really pleases me to see yet another relevant question be asked that we all know. It has and continues to adversely affect the timing of care we are able to provide our patients. So first off, could you share your motivation behind choosing this topic that I'm sure is something that most, if not all, bariatric surgeons deal with?
Well, this topic was chosen because I was relatively new to Yale. I spent 16 years at Stanford and then came to Yale, and I found out that this was a fairly routine process, which is to do toxicology screening in patients. And, I inquired as to why, and there was still an insurance company that insisted on it, and it became almost like a legacy requirement for people undergoing bariatric surgery. And I got some feedback. I got some feedback from patients that said, listen, I'm a vice president for accounting. I'm not going to be doing any sort of like illegal drugs or anything. Why am I having to do this? And I thought that patient posed a very good question for me. And so that's why I endeavored to see if any of this testing resulted in any sort of improvement in outcome.
Very awesome. Very good. So what was the crux of the findings from the study that you reported?
So we reviewed a lot of patients, over 1,000 patients in a 3-year time frame, and we wanted to see if they were positive for any sort of substance or if they were negative. We found that roughly about 1 out of 10 patients had a positive toxicology result. Most of them were for opiates. A few were for the substrate for nicotine, codeine. So we did find those were the two most positive results. What we did not find, though, was that if you were positive, it did not result in a negative outcome for patients, meaning there wasn't more risk of leaks, there wasn't more risk of bleeding, there wasn't more risk of readmissions, and the weight loss was the same. So we felt like, if it's the old saw and something we're taught in med school, don't order a test if it's not going to change what you do. And so that we found that ordering this test did not change what we do. So as a result, we've retired toxicology testing and have given feedback to the one insurance company that was doing it, that was requiring it, and happy to say they don't require it anymore.
Wow, that is great. I think this is the idea behind getting good quality literature out there, is to affect change that can benefit both, obviously, as a practice of bariatric surgery, but also the patients. That's good to hear. Well, so since it's possibly the first study to suggest that preoperative toxicology screening is probably unnecessary, do you think for wider, more uniform application, maybe even nationwide, are there any further aspects that need to be studied in order to fine-tune the approach? Or do you think it's pretty broadly applicable as kind of this data stands now in the near future?
I think, like any sort of study, it's always better to have more than one center. It's always better to have longer follow-up, though we did have at least 1-year follow-up for our patients. But that being said, I think, we had 1,000 patients. And so I think it was pretty telling. I think, the one thing that I came away from this is yet another reminder that patients with obesity face stigma. Why is it that they were required to get toxicology screening when you go in for a cancer operation or a heart operation or even a foregut operation, for reflux, and nobody's testing you for in toxicology results? So I think part of this, honestly, is a stigma. effect that you see with patients with obesity. And I'm glad to see it go away. And I think maybe we ought to start looking at some other things. Why are we doing things routinely? And I'll be heretical here. One of them is the psychological evaluation. I think most of us as practicing bariatric surgeons know when we have someone that may be a problem. I think our bigger problem is having psychological support after surgery. I'm not certain that the evaluation should be routine anymore.
And those are all excellent points. Very good. So you mentioned that it's changed your practice there at Yale. So just out of curiosity, at your previous job, how long ago did you do away with toxicology screening, which I'm assuming you mentioned you had?
Long time ago. It was
Gotcha.
probably, at least 15 years probably. There was some in the beginning, but, very little afterwards. My practice was in California. So if I tested people for like, THC, I'd find a pretty high positive rate. So, especially nowadays with marijuana being so prevalent and also legal in a lot of places. So it's just something we have to contend with in surgery in general.
Gotcha. Do you foresee challenges? What is the topmost challenge that you see that might be a barrier to a much wider adoption of this practice?
I think a lot of it will still continue to be some prejudice against patients with obesity. Some of it may be, some issues with patients from lower socioeconomic status where you assume that there is something going on with those patients. And as with many sort of prejudices, they're not rooted in fact or basis. But there may still be, people that believe in that, like, patients should be tested for it. And if they are positive, then I'm going to withhold surgery from you. As our study showed, though, even if you were positive, you still lost weight to the same degree and you did not have worse outcomes.
Very good. Any other key elements that you would like to highlight that you came across either during the course of the study or something that you feel might not be as apparent to readers, just someone who's reading the text?
The one thing I would like to point out is that the testing itself costs money. I didn't detail, how much it ended up costing, but it was several $100s per patient, that somebody has to pay for. You add that up over 1,000 patients, it really boosts the cost of care. The other cost to be paid here is the delay. We had, I think, an extra almost 100 days, 3 months, where patients had to wait. There was also repeat testing. So I think that's another cost to be paid. We have to figure out what we actually truly really need to take care of these patients and take a fine eye to look at it. Bundle payment, that you see in orthopedics may come to bariatric surgery one day, and we have to examine our episode of care and really figure out what's relevant and what's not relevant so we can deliver on that value equation.
Very good. I did also see mention of a dropout rate, which I completely agree with. I think it's something we all come across, unfortunately, and everyone, I'm sure, would like to reduce that dropout rate because as it is, the access to actual bariatric or metabolic surgery or care that patients need is just a fraction of what it needs to be. Add a dropout rate on that, and that further decreases what we're able to do for patients. Did you notice any change in the dropout just by changing this one variable, either previous job or here?
No, it's a good question. You're a good researcher. That's something we should follow up on to see if the change in practice led to less of a dropout rate. The timing of the study was, the 3 years prior to COVID. I think one thing we've noticed since COVID, at least for us, is that people were really focused on getting the surgery because, as others do, that surgical weight loss can decrease risk of complications of COVID. So I think since then, our dropout rate has been lower, but it's a good question. I'll have to look into that.
Excellent. Well, I just want to thank you for taking out the time to speak with us and sharing your unique insights in this topic and your article. It was really a pleasure talking to you, sir, and I really enjoyed the conversation. I look forward to having more and more from you and hopefully meeting you as well in person sometime.
Yep, look forward to it. Hope to see you in Vegas.
Absolutely. All right. You have a good day, sir.
Take care now. Bye.
You too.